All right, if you're seeing a stroke patient with an elevated Lamb score, here's a couple tips that can help you decipher whether or not it's a hemorrhagic stroke or an ischemic stroke. So here we go. On the bleed side of things, typically head bleed patients will have a pain component. When these meninges get irritated, you will get a headache and your reticular activation system will let you know that you're having some pain. Also, if you have some trauma associated, that might be where your pain is coming from as well. On the LOC side of things, typically bleeds can get sleepy, bleeds can get lethargic, and bleeds can drop their GCS as time goes on. Let me illustrate that. To be conscious, all you need is one working hemisphere and a reticular activation system. So if I had a head bleed patient and they had an expanding mass lesion or a space-occupying lesion, let's say from an interparenchymal hemorrhage or an IPH, what's going to happen is one of these blood vessels is going to burst inside the parenchyma of the brain, and eventually you'll start having blood filling up this area, and it's going to start pushing some of the other tissue into places that it's not supposed to be. One of these areas is your reticular activation system. So if you herniate onto your reticular activation system, that will cause sleepiness. Now, the history is important. So tying this back to trauma, like I said, the history is always important for neurological cases. Is this patient a geriatric or an alcoholic with a smaller brain mass inside of their skull that's making them more likely to bleed? Do they have an AVM, an arterial venous malformation, that makes them more likely to bleed? Are they on anticoagulants or blood thinners? That combined with trauma all makes you more likely to bleed. Now down here, I have roughly 20% of the time. So out of 100 strokes between ischemic and hemorrhagic, about 20%, depending on which book you read, about 20% are bleeds. And so most of the time, it's probably not one, but it's really, really good to look for these signs in case it is. Get them to the scanner, get them to the right center. Now, on the clot side of things, typically these patients are more awake. And typically they don't have pain because they don't have that meningeal irritation and they're not messing with their reticular activation system. Let me show you. Here's the MCA coming off of your circle of Willis. MCA will come up here, and let's say we've got a blocked left MCA. Now remember, I said you only need your reticular activation system in one hemisphere to be conscious. With a clot, you won't see the same expanding mass phenomenon that you will with the IPH. The clot will just sit there. Yes, you might get some cerebral edema, but that happens over time. I'm talking about the acute setting. You will not have this brain sort of herniating into or onto this reticular activation system. You're not going to have any impeded blood flow to this area. Also, if you have an MCA occlusion on the left side, you still have one good hemisphere over here and an intact reticular activation system. Therefore, these patients are awake, and most of the time they don't have pain. It's really important to get a history on these patients as well. History to include sort of clot history. Do they have AFib? Are they on blood thinners? Are they compliant with their meds? Have they had a DVT? Are they a smoker? Etc., etc. History is always important. And now what I have down here is 80% of the time. So going back to Vegas odds, out of 100 strokes, 80% of the time, depending on which book you read, once again, 80% of the time, these are going to be clots. And a special note of that 80%, 50% are MCA occlusions. And it's always good to understand what MCA occlusions look like, and I'll show you. Typically, your eyes are going to be looking at the stroke, and you'll have a contralateral hemiparesis. In this case, they would have a leftward gaze preference and they would have a right hemiparesis. Anyways, I hope that helps. Get out there and do some good assessments.